Hi, and welcome back, everyone. We hope that you had a great lunch break. My name is Dianna Cochrane, and I'm the Policy Analyst Justice Lead for CMHA Ontario. So we are thrilled today to have an amazing lineup of speakers to share their unique perspectives on today's discussion topic. And it is my distinct pleasure to introduce our keynote panel and our moderator for this afternoon. So I'll begin with our moderator, who is Dianna Cochrane, who is on your screen at the moment. So Dianna is the manager of the Forensic Mental Health and Justice Unit within the Mental Health and Addictions Division at the Ministry of Health. And now I will also introduce our panelists. So they include Laurie Griffith, who is the Director of Crisis Services for the Canadian Mental Health Association Thames Valley branch. We also have Charlene Humble here with us, and she is the Inspector of Community Mobilization and Support branch of the London Police Service. We also have Raquel Hamlet, who is the Manager of Wellness Community Crisis Response Team at Taibu Community Health Centre here in Toronto. We also have Liberty McAllister, who is the Crisis Response Supervisor for the Canadian Mental Health Association Thunder Bay branch. We also have Gord Davies, who is a mental health nurse with St. Joseph's Hamilton Healthcare. And last but not least, we have Peter Wiesner, who is the team supervisor for the Crisis Response branch at the Hamilton Police Service. And so with that, I will turn it over to Dianna to begin.
They're in a mental health or addiction crisis. In partnership with our colleagues in Soljan and the provincial HSJCC, we've been watching these teams kind of change over the years to better meet the needs of their communities and the people they serve. I think that we generally think about a mobile crisis team as just a police officer traveling with a mental health worker, but we know there are so many more models that might be appropriate for your communities. And I did want to highlight some of the work we've done with the HSJCC. So there is a mobile crisis framework and toolkit that you should be able to find on the HSJCC website. And that goes through a lot of the different models, specifically if you look at page 17 and 52. I looked them up this morning to make sure I had the right pages. It's amazing all the different alternatives that people have come up with, making sure that we're able to meet people's level of needs, their level of risk, you know, the possibility of aggression, high risk situations versus low risk situations, just to make sure everybody's used appropriately and gets the programs that we need. So we're excited to hear the panelists today. I'm excited to hear the panelists today and to hear about the different programs that are out there. I think we've got a good representation with the 4 different programs today. So yeah, I don't think anybody really wants to hear from me anymore. So why don't we move to the panel? So there are 4 questions that were predetermined. So I'm going to go through the 4 questions with the panels. Each group will have a few minutes to give their share their knowledge and information. And then after we're finished with those 4 questions, we'll open it up to the audience. So there is a way for you guys to ask questions of the panelists. I think, if I understand right, it should be on the top right of your screen if you click on Q&A, and then you should be able to enter your questions there, and Aaron will come back after the panel discussion to kind of moderate those questions. So hopefully this goes as planned. So why don't we start with question number 1, and I'll ask Laurie and Charlene first. So can you guys please tell us about your community's crisis response service / models? How does it work where you are?
Yeah, thanks so much. So I'm Lori Griffith, and so I'm from CMHA Thames Valley, and here with our London Police partner, Charlene. We're really kind of excited to talk about mobile crisis response because it's something we've actually been doing for a very long time in our community. So what we'll do is we're just going to highlight kind of our 3 different models. So because we're from the Thames Valley area, we do have like urban, larger city kind of geographic areas, but we also have a lot of rural communities as well. And so what we have is kind of different models based on where we're located. So the first 2 models we have are located in the City of London. One is called our crisis response team, and it's actually been around before any talks about mobile crisis was something that was popular. So it is a traditional kind of 2 addiction mental health worker led team. They get dispatched, they work out of our crisis center here in London, and they get dispatched through our reach out, so our crisis response line. And then we also have opportunities for our police services to call directly to the mobile team, and for our London paramedic services, Middlesex paramedic services, to also call directly to that team. And so what the goal is those 2 addiction mental health workers will go out to scenes and help resolve any addiction mental health crisis there, also help transport to hospital if required, and or to our crisis center if that's needed, and access our stabilization beds. So that program has been around since officially 2012, but CMHA has been going mobile long before that. I actually can't remember a time that they weren't going mobile, but we would not have been able to do that without the partnership with the London Police Service and our Middlesex London Paramedic Service. That's the one London program. And then the second London program is also a unique kind of a twist of the traditional kind of mobile team we had and the MCERT teams, and it's called our COAST team. So it's a community outreach and support team. So this one is a unique partnership with CMHI Thames Valley, London Police Services, again, Middlesex London Paramedic Services, and our St. Joe's Healthcare. And the way we kind of describe this is an approach that is a healthcare-led but police-supported. And so instead of them being the traditional MCERT teams where they're located and embedded within the police department, they're actually embedded within our crisis services as well at CMHA. The team is located here, and they have 3 main goals. One is to be kind of proactive. So the police will have a list of individuals each month that are high users of emergency services, and we proactively go out with that team to try and reduce the potential of crisis. They also will do follow-ups. And then the big thing that they do is they will help support take calls out of the 911 queue, which is where it becomes more traditional, like an MCERT team as well. The way that team is made up of is it's 1 police officer with 1 of the healthcare workers. So it will either be someone attached to a CMHA worker, an ACT nurse from St. Joe's Healthcare, or our Middlesex London Paramedic Service. So that one of the things that that project is really starting to see a shift and starting to do more around supporting the LPS, or the London Police Services queue. And again, it's a great partnership. So before I move to kind of the traditional MCERT models, which are not located in our urban area, I'll just move to Charlene maybe to talk about the partnerships and the importance of that.
Yes, hi, thank you. I would say this relationship and the importance has just been, it's incredible. It allows us to support those with mental health issues in our community, I think in a way that's best suited for them. As we all know, sometimes police, typically in their uniforms, can sometimes, make a situation worse rather than helpful. And one of the other pieces is typically when our COAST team is now involved, there are very, very little apprehensions, whereas when our uniform officers go out, sometimes just based on experience, the COAST team is out there with their mental health workers. So that alleviates a lot of that. And I can attest to using the crisis response team myself, 15 years ago back on the road as well. And it's been very, very helpful, particularly in those situations where we don't have enough information to apprehend, but there still are concerns. So they were able to assist us in that way, and so that we could get back to the road doing the calls.
Yeah. And I think with our COAST team, it's noteworthy to say that we actually have not achieved sustainable funding for that, but through the partnership with the 4 organizations, we have all committed to see the success of this, and we're all committed to trying to make it part of our everyday budgets until we can get sustainable, because even just last year, we saw 1,500 ED diversions as a result of that. So, and then the third models that we have are the traditional kind of MCERT models. So Thames Valley region is very big. It's London, Middlesex, Elgin, and Oxford counties. And so we have partnerships with all of our police services across the region. So all of the OPP services, the Woodstock Police Services, St. Thomas Police Services, Elmer Police Service, and Strathroy Caradoc Police Service. So when we talk about our MCERT teams, we have essentially 4. And when Dianna, you were holding up the models, we actually have all of those models. So depending on what region we are, each of the police services does them slightly different. So we have the embedded live response model in a couple of our locations. We have the live Cove response model, and we have also follow-ups embedded across. Some we have dedicated officers, and some we have where they go depending on what officer is on shift. We see strengths and, to all the different models. Where we see, it's all about the relationships and the partnerships where it's, coming together, having communication and tweaking things as they go so that we can increase the services and make sure that we're serving people in the community. So those are our models quickly.
Okay, Raquel, can you describe the program that you're part of?
For sure. So I am in Scarborough, in Toronto. So we actually cover 3 police divisions. The way that it was split up was essentially, it was a pilot program given to 4 different community agencies across Toronto. So we got the Northeast region. So it's funded by the City of Toronto, started in April of 2022 and supposed to go until April of 2025. Just last Friday, we actually, they've kind of fast forwarded things and announced that we'll be moving to full expansion and more funding even before 2025, because the program is pretty successful in terms of the model and how it's working. So we serve 16 and over. For us specifically, only in the Scarborough area. The other 4 regions will serve the Northwest and certain parts of downtown. So essentially, it is 2 mobile crisis workers. All of our calls come through either 211 or 911. So working to try to move calls away from 911 and more towards the community service in terms of 211. So we get our dispatches. They come through the radios, and we confirm the calls. We head out, whether it's to clients' homes in the community. We meet clients wherever they need to be met. And sometimes we're transporting to hospitals. Sometimes we're doing just some de-escalation. We're giving resources. The benefit of the program is that after the initial crisis, there's always a follow-up phone call. So follow-up phone call within about 2-3 days to kind of see, that now that the initial crisis is over, what are some of, the social determinants of health that are not being met? So are there other things that actually led to the crisis? So when we do that, we're able to then connect people to culturally appropriate services. So whether it's through TIBU or through other agencies that we found throughout the community. And then also too, they can also get connected to post-crisis case management, which is a huge piece for us, because the case managers will actually follow clients for 3 months, 6 months, however long it takes them to get connected to services. They'll do that piece.
Thanks, Raquel. So Liberty, what about you? Can you give us just a description of your program? Well, I think you're still on mute, Liberty.
Sorry, I'm from Thunder Bay, which is Northern Ontario, and we have in Thunder Bay 4 crisis programs. We have our crisis response phone and text line, which an individual can call in to or text the line for support in de-escalation, mental health supports, connection to appropriate resources to assess safety. The crisis phone and text line services the City of Thunder Bay and the entire northwestern Ontario region, which is anyone residing from Kenora East to Wawa. And this runs 24/7, 365 days a year. We also have our mobile response, which is an individual or family can consent voluntarily to having on-site mental health and safety supports. The mobile team is available for community outreach 12 to 12, and that's in the Thunder Bay area. The MR team is dispatched through our crisis response workers on our phone and text lines that are assessed in need for face-to-face intervention and linked to other services. Then in March of 2021, we opened the Safe Bed program, which is 24/7, staffed by 2 crisis workers who are able to assist individuals to identify needs and individualized program referrals in the areas of life skills, accessing treatment, addictions, mental health, parenting, healthy relationships, domestic violence, stress management, healthy active living, human trafficking, harm reduction, employment, education, housing, and case management. And then there's several different avenues to access our Safe Bed program. So police services, our impact, and through our Thunder Bay Regional Health Science Centers. And lastly, our local detox facility. And then we have our impact program, which is the Integrated Mobile Police Assessment and Crisis Team, which began in January of 2021, which consists of a Thunder Bay Police Services officer and 1 crisis response worker. And that team is 24/7 coverage, responds to calls through 911 that are deemed to be mental health in nature. And the team is able to divert from other emergency services by referring to community-based services, mental health services, housing, shelters, supports, detox, and addiction treatment. And we also have included in our services an addiction specialist that can assess, plan, develop, and connect to support services for individuals throughout the recovery journey. And I think the most important thing to say about our programs is they're all really interlinked. Our impact team is really embedded within the Thunder Bay Police Services, but there are times when our Thunder Bay Police may call our regular crisis line if the impact is not available. And if it's a lower level call, we might be able to send out a mobile response team where police intervention necessarily isn't needed. And our detox for the Safe Bed program, our detox pathway allows for, say, our impact, who might see somebody in the community and somebody doesn't seem like they're medically stable enough to be within our Safe Bed program, they can let the detox facility or the hospital know, and they can later be referred to us as well. Yeah, and those are our services.
All right. And then last but not least, Gordon Pete, do you want to describe the programs you're in?
Sure. I think Gord's going to let me start off here. I just want to say first and foremost the great relationship that we've had with St. Joe's for the last 26 years. Unfortunately, 26 years ago, we had some really bad circumstances that happened in Hamilton that allowed us to invent what was supposed to be the changing of what policing is, and that was the partnership that was created 26 years ago in 1997 with St. Joe's after the untimely death of Zachary Antidormi. That was when we first created that partnership. And just like Lori said, to piggyback her words, I think having that community partnership is the only way that policing is going to move forward. And luckily for us in Hamilton, we've had a very great relationship, not only with St. Joe's, but a lot of other community partners over the years. And the 4 programs that we currently deploy out of Hamilton is the originating Coast model, which again started 26 years ago in 1997. In 2011, we started the Social Navigator program based on a partnership with EMS. And that was to deal with the high users of services that were constantly calling 911 or calling the Coast office, and streamline, instead of having the same group of police officers respond to that individual every day, we made it so it was more of a medical response with EMS and police. And in 2013, we were able to launch our MCERT team, which was the first one in Ontario. And most recently in 2022, we're very happy to say that we were successful with the CSP grant. For those that know, the Community Safety and Policing grant through the Solicitor General. We were able to get an $8.3 million grant that is paying for social workers to be deployed onto the streets with police as a part of our Social Navigator team. The concept behind that came from the times of COVID, when we really had to look back as police officers and say, is this our lane to operate in? And we realized that there was a lot of homelessness, addiction, and mental health where we knew that we weren't the subject matter experts in the front of the field, and how could we do more to bring those subject matter experts, the professionals, to the front of the line? So with this risk model, we were able to create a multidisciplinary team of experts from our community in the field of homelessness, drug addiction and mental health, who work together in a team-led setting to provide the resources needed to help the most complex and marginalized individuals in the community. The best part about this is it's just not a partnership with one community partner. It's a partnership with 7 or 8 now. And just to give them a shout out, because it was them reaching out to us, these different partners in the community, wanting to have this police partnership. And it was Interval for Women, St. Joe's Healthcare Hamilton, YMCA, the Hamilton Regional Indian Center, the Canadian Mental Health Association, John Howard, and Wesley Urban Ministries. And we were able to pretty much check the box of everything that comes with marginality, what we like to call the marginalized triangle of homelessness, addiction, and mental health. Now, we actually have these individuals in our police station responding with our social navigators to deal with the homeless crisis, the mental health crisis, where it's not necessarily an emergency response. The one thing I like to say before I pass it over to Gord is everybody's dealing with crisis. Every day of their life, people are dealing with crisis. But when we insert a police officer, we're elevating it to an emergency. And we want to respect the fact that people have these very intimate, very personal crises, where there's people out in the community who specialize in mental health, like Gord, or people who specialize in addiction and homelessness, that are much more antiquated to bring those resources to those people that need them, and allows us as police to give them the support they need when it comes to safety and security. And the partnerships are still alive and vibrant today. And again, I couldn't be more thankful to have the people within Hamilton and the partners within Hamilton step up and want to work with us.
Yeah, so I've been around for the last 26 years. I started in Hamilton 26 years ago when the Coast program first started up. And at that time, it was literally bringing 2 police officers from the Hamilton Police Service into the Coast office. Coast at that time was a community-based agency, but later to have bigger roots connection to the hospital. And we were hiring nurses, social workers, and occupational therapists to go out and do crisis intervention with their partner being a police officer in plain clothes. And as you know, in Hamilton, things kind of evolved. Hamilton has developed some models that other communities have developed. And now I'm seconded over to Halton Police Service, where we have very similar models, a Coast model, but it's with CMHA Halton and the Halton Regional Police Service. I am a St. Joe's employee, seconded over as a nurse to be there with their MCERT program. And their MCERT program started about a year after St. Joe's partnered up with Hamilton Police to do theirs in 2013. Halton Police started about a year later and has just adopted the exact same model. So we have these nurses, social workers, occupational therapists, and now even psychotherapists. Whereas the police officers being seconded to the Coast program to do crisis response, kind of a secondary response model, the MCERT program now being a first response model, and you're having mental health workers seconded to the police service. And that's been going on, as I said, in Halton for early 2015 kind of range. And we do approximately half of all the mental health calls that come in through 911 dispatch in Halton region. And then we have CMHA Halton running their Coast program with, again, a partnership with Halton Police Service. And we have a great partnership between that. You have to have all 3 partners in place: community agencies, hospital, and police, all on the same page to develop these crisis models. And it's not so much exactly which model you adopt, but having the right people in the right agencies who are willing to buy in, having those champions, having those people that desire to do the work that needs to be done in the community. It's more about the people than it is the model, but the models have to fit the community, and the community has to have basically the hospital on board, the police service on board, and again, the community mental health agencies on board. And Halton and Hamilton have been very close in sharing what works and what doesn't work, and then morphing the program over the years. So I've seen a lot of changes over the last 26 years. But that's kind of how Hamilton and Halton work very closely together. And even though I'm a St. Joe's Hamilton employee, I'm permanently seconded over to the Halton Police Service, and I do 911 calls with a police partner. We have 2 teams on the road every day right now, from 10 to 10 and 1 to 1. And then the Solicitor General's office gave us temporary funding for a 3rd team, which works Monday to Thursday 1 week and Tuesday to Friday the next week. So we kind of have 3 teams, or 2.5 teams on the road in Halton, whereas in Hamilton, they have 4 MERT teams, 4 rapid response teams on the road every day. And that's kind of how things run in Hamilton and Halton.
Great. Thanks so much, everyone. It's great to hear about how your programs work, but also the histories of them, and also the partnerships, not just within your community, but with other communities to kind of learn from each other and develop best practices. So thank you, everyone. So we're, just so everybody knows, we're running a little bit over time. So moving forward, if we can keep our responses maybe closer to 3 minutes, just so that we can cover everything, we want to make sure that the audience has a chance to ask questions as well. So the second question, and Liberty, we'll start with you. The Mobile Crisis Response Framework and Toolkit encourages crisis response teams to collect evaluation-related data to inform the development of evidence-based practices and criteria for long-term and sustainable funding, while also creating consistency among measures to track the success of each program model. Can you please tell us what data you collect and use to demonstrate success in your community, and what are the most important measures of success for your program?
We collect weekly statistics on the number of contacts, ED presentations, consenting involuntary ED diversions with outcomes and dispositions of whom the client is supported by, left in care of after the interaction. We also collect the stats on follow-ups, referrals to community connections to best meet the needs of the client. And other important areas collected would include if a client repeats within 7 days, if the client is under the age of 18. Our current data from the commencement of the program, which until about October 18th was 3,656 contacts, 1,080 emergency department presentations, 1,923 emergency department diversions, and 625 other, which would include calls that were not deemed to be mental health in nature once arriving on scene. And the success of our program is directly linked to the positive partnerships that we've developed with our policing partners. Crisis intervention training is offered to officers and crisis staff members to help support education on best how to support clients experiencing a mental health crisis. And Thunder Bay Police Services offer crisis staff support and education around cultural sensitivity, situational awareness, and trauma and violence-informed response. So we've really, the success is really our team that's on the road and, you know, really looking at someone and trying to use the least intrusive measures in order to intervene with someone.
Great. And Gordon, Pete, what data are you guys looking at in Halton and Hamilton?
I could start up with that. We use 2 collection methods for data from a police side. On Coast and MCERT, we use our dashboard, and our dashboard's really good and unique. It's a home-built program where we can collect imperial data that will help us with our, more importantly, the apprehension rates. And just to give you an example, we can tell with one click that approximately, this is from my last look, 67% of the time that patrol is responding to a mental health crisis, we're apprehending. When we insert a mental health worker with a mental health officer, we're apprehending 18% of the time. That's a 55% decrease in apprehensions by having that expert like Gord at the front of the line, because he has that ability to utilize the resources within the community. When it comes to our SMP and risk file, we use an IM Health type database where we derived it from the EMS, where it's more case managed on that side, where we have a coordinator that brings everything together and puts it into a health database that we're able to capture in.
And in Halton, so we collect a lot of data regarding the number of calls that are mental health calls. So in Halton, about 650,000 people that we serve, there's about 3,500 calls per year coming into 911 services of a mental health nature. And approximately, 55%, 60% of those calls are being dealt with by MCERT teams. And then an officer who has no CIT training, no specialized training, they're apprehending about 75% of the time. An officer with some CIT training, about 40 hours of mental health training, they're apprehending about 45% of the time. And then if a rapid response team is on scene, usually they're apprehending about 10 to 15% of the time. And then we look at the number of people who actually have passed away in the last year, and that's on average in Halton about 35 to 40 individuals, and literally 60% of those people never had any contact with 911. So it's not like these people have come to the attention of services and then didn't get the help they needed, the vast majority have never come to our attention, and the ones that did unfortunately have been attempted to be supported services, and unfortunately a small percent of those do end up to go on to end their life. But we do capture things like what is the presenting problem and what is the outcome in terms of were they diverted from hospital, diverted from being arrested, what kind of services we were able to hook them up to, community or hospital services, and again, a lot of times it's do they have shelter, do they have access to food banks and access to social services. So it's a lot of connecting services. We often refer from rapid response over to the Coast Halton program, and they would do a follow-up visit in the next couple of days, and then they also captured various demographics and other information about what the current referral was all about and what the outcome was upon the end of their time with that agency. So that's kind of how Halton works, very similar to Hamilton.
Thanks. Raquel, what about you? What are you guys looking at typing?
So our data is collected by CAMH, but they get the data that we give them through our electronic medical recording system. So we're looking at, similar to the other programs, number of calls per month. Is there any CAS involvement, 911 co-assist, because that does happen for us sometimes. Although we're non-police led, we may have situations where we need police to step in. So we're also looking at how often do we need them to co-assist. Transfers to hospital, numbers of like sociodemographic information as well. So we want to understand what parts of Scarborough are they coming from, what are the presenting issues, and then more so the follow-up stuff as well. So how many people are just coming in for crisis and then never again? How many people are coming in for crisis and then being referred to culturally appropriate service, being a follow-up to, referred to follow-up services, case management. It's a lot of things that we're looking at in terms of data. And I think for us, one of the great things that have come out of doing this in terms of success is really building a more positive relationship between, the Black community, the Indigenous community, and police services. Because again, there have been situations where we've had to have police on scene, and I think, them seeing us actually work together, and the understanding that this is never about, defunding the police or anything like that. It's really just about detasking and taking away a piece of the work that, they're not necessarily trained to do. So bringing in the mental health experts to do that, we're able to work hand in hand with our police departments that we have here. So it's been a really great success for us.
Thanks. And Lori, what's happening in the London area? What are you guys looking at?
So yeah, in the London and the Thames Valley area, I think very similar to kind of what everybody's talking about. So I'll try not to duplicate too much, but obviously our live calls are something that's really important. Our follow-up calls, a number of unique individuals is something that I think I haven't heard a lot about, so that we know, is there a duplication in terms of, are we seeing the same person over and over again, which speaks to what I was talking about with our Coast program, which is slightly different, but in terms of that high user of emergency services, so that we can proactively go out. So we want to see the unique individuals. Obviously, diversion from hospital. We're also really capturing the results in mental health apprehensions. When we're looking at all of this, the big thing for us is around how we measure success is if it's resolved at the scene. Are we looking at connection to other services, and what are we doing through that follow-up? What are the referrals, and is the referral sticking? Like, are the people following through with the referrals that are made? So that is a really big piece for us. And then if it resulted in a mental health apprehension, which we know that sometimes that is the next appropriate step, and that we don't want to always say it's just ED diversion. It's also about connection to the right level of care. And if hospital is appropriate, then we measure, did it result in a Form 1? Because then we want to know, did it result in an apprehension that was also then agreeable with our partners, that made sense, and it was for the best place for the person? Because then we go back and say, okay, could we have done things differently? Could we have tweaked things? Should something have done happen differently? So that is probably the big thing that I haven't heard. Just thinking other things that I maybe haven't heard. I think we talked a lot about already the community referrals. And then it's just about reduction. So we look at that unique individuals when we've given them the right kind of referral, and are we seeing then a decrease in services after that? And so we kind of measure that trajectory once connection to service.
So from the Ministry of Health point of view, it's great to hear about all the data that everyone's collected. From our point of view, all we have is like medical information. So we don't know how many people, you know, did the police have to use the Mental Health Act with, or how many arrest diversions there were. So it's great to hear that you guys are collecting such rich data. So question number 3, we'll start with Raquel, because I think Raquel's program is the newest. With the development of any new or enhancement of any existing crisis service comes opportunities to learn what works well in your community and what doesn't. From your experience, what have been some of the main challenges or lessons learned?
I think for us, especially because of the community that we're serving and where we're situated, one of the biggest challenges in the beginning was getting people to trust actually calling 211 and understanding that, you know, they don't need to call 911. It was a lot of back and forth because we were going to be using both for the beginning, because it would take people some time to kind of move over to 211. A lot of the, you know, Black community, Indigenous community didn't want to call 911 in fear that, you know, police would come and it wouldn't be a positive outcome. So that was one of the challenges that we had in the beginning. As we continue to kind of progress and do things, housing really became a big issue, because we're meeting a lot of people that were precariously housed, you know, on the side of the road, at the side of the highway, and trying to find shelter for them. Right. So, I mean, we are equipped now with 2 shelter beds and 1 crisis bed, but they're always full. So the shelter bed, the turnaround time is 3 days. The crisis bed is 30 days. But yeah, there's consistently somebody in there. So it's very difficult, you know, if our bed is full already, we don't have anywhere to put people. So it is a challenge. You know, we brought it forth to the city, and they are looking into see how we can help to facilitate that particular one. As well as to just, you know, some of the systemic barriers that exist for our community, you know, mistrust in the system and long wait lists for services. So it's one thing to, you know, get somebody in and say, okay, I'm going to refer you to, you know, a counselor, but then they're sitting waiting for a year before they're able to see somebody. So we really focused on, you know, not leaving clients on their own. So if it is a service that has a longer wait list, trying to stay involved with them regardless. So having the teams do follow-ups with them, case managers check in with them. So that's kind of been how we're building rapport and getting people to trust us a little bit more. I think as well too, in terms of just needing more resources, because we are covering all of Scarborough, which is a very dense population. It's about like 20-kilometer radius that we're covering. And we only have 1 van in the day and 1 van at night. So it's a 24/7 service. Shifts are 9 a.m. to 9 p.m. and then 9 p.m. to 9 a.m. The odd time when it gets busy, we may be able to have an 11 to 11 shift. So we may run both vans at once, but definitely needing more resources for a much bigger team for sure.
Liberty, what about you? What are some of the challenges or lessons learned up in the Thunder Bay North region?
I think some of our challenges is the addictions concerns that we have up in the northern area and with housing. The housing wait lists are really, really long in Northern Ontario, and that becomes a problem when, say, our impact team is going out and they need to place somebody, because even the shelters are quite full at times. So I think that those are some of the issues, but I think the success really of the program is the diversions and helping to relieve some of the pressures from the emergency departments and other emergency services, and being able to leave some clients in care of self or with community supports in order for police to be able to attend other calls as needed. I think another positive with our impact team is that if a client needs to go to hospital, they have an advocate with them that can also explain what the presentation was in the community and give a better idea of what is actually going on with the client.
Thanks. All right, Charlene, Lori, what about in your region? What are some of the challenges or lessons learned?
I think like Charlene and I, when we saw this question, we spent a lot of time reflecting on kind of lessons learned and challenges and all of that. And so definitely what everyone is speaking about in terms of resources, the lack of available resources to support the complex needs. Obviously, those of us have been in the addiction mental health field for as long as many of us talk about, it's 20 years. The complexity is getting more complex. It's getting harder. And the programs and services and weights is a challenge. So even when we get and to be able to support individuals, we don't always have that. We know what the right referral would be, but we don't always have that, or they're full. or it's a long wait list or something like that. So that, I mean, that is obviously something that is really hard. And I think that contributes to fatigue for our employees as well, and frustration in the system. I think also for us, one of the big challenges is funding. So obviously we are always appreciative for every funding that we get, but a lot of the times it is grant type funding. So you build a program or pilot funding, you build a program, you're doing really well, it's being supported in your community, and then how do we sustain that within our existing budgets? And we just don't have that. So then it feels like a loss or something being taken away from our community when we've proven that it is a worthwhile program. So that's kind of the battle that we're with our Coast program right now, is trying to find sustainable funding. But as I said before, we're all committed to the partnership, knowing that these programs are essential to our community. And then simple things, and Charlene and I kind of laughed and joked about this, and feel free to jump in, Charlene, but it's just like working across different organizations. Like we have different working philosophies, really simple things, like we have different worldviews, different training, we have different union rules, regulations and things like that, that sometimes I think we forget that actually takes a little bit of like growing pains to kind of work through. Even like right now in some of our programs, we're looking at changing schedules, and we're like, oh, we're 4 organizations. We need to figure out, can we change schedules, and what are the rules with the unions in order to be able to do that. So what we've learned, and one of the things that I'm most proud of being a part of this team, is that it's the regular connection. We just need to have transparency, honesty, and kind of like work out, the good, bad, and ugly together. So we regularly meet and we connect at all different levels. So whether, Charlene and I are at the governance level for a lot of these tables, but we also really support the frontline and operational managers also to connect, to be able to work that out. And then we think one of the best things is collaborative training. So we've done a lot of collaborative training so that people are hearing the same messages at the same time, regardless if it's not maybe, like, for instance, we had some of our staff go to negotiation training the other day, just in terms of learning some of that skills. Our mental health workers probably are not going to be as involved, but being there, hearing the information, it increases a common level of understanding where each other is coming from. And then we commit to PDSA cycles, so the Plan, Do, Study, Act, and like tweak and tweak and tweak as we need. So sorry, Charlene, I probably spoke on some of your points. I don't know if there's anything else in terms of lessons learned that you've thought of.
Well, no, I just wanted to touch a little bit more on what you said. Like, I'm relatively new to this position, and one of the first things, even just with my team, like you said, was the communication piece, right? You've got to get everybody in the same room sometimes, and there can be a lot of things taken the wrong way or not correctly if it's by email. So just learning those little, pieces, and just making sure that we have that face-to-face conversations. And like Lori said, I'm so grateful for our partnership that we have with them too, that we're able to do that. We hear something's going on, we connect and we work it out every time. And I don't know that, that's the common practice or, possible to do in some other situations.
All right, thank you. All right, Pete and Gord.
If I could steal Raquel's thunder about detasking, I think that's been one of the bigger things we've heard from the lens of police is why police. And the reality is we went back and reinvented it. We just looked outside of the box. And as police officers, we have to go back to the 9 principles of policing. And the 2 most important principles that we have to follow is law enforcement and public safety. And I'll pull Gordon for this example. Gord is much more of a specialist and a subject matter expert in mental health, but if Gord can't do his job in a safe environment, we as police need to ensure that we do the right things to allow Gord to operate in his lane of traffic. And again, to steal some of Raquel's thunder, I think the biggest hindrance we have is that community trust with police. I know post-COVID and everything that happened around the world, especially in the US, made people look at police, with the same brush. And we as police, we needed to stand up and we needed to articulate ourselves and figure out how we could do better. How could we be a voice to the community, and how could we also be an advocate? So you look at something like homelessness, and that guy who's in a tent in a park didn't wake up today and said, I want to live in a tent in a park today. But that offense that he's committing is no different than a kid riding a skateboard in Lime Ridge Mall. It's engaged in prohibited act while on private property. So we took the lens and said, okay, we need to bring the housing experts. We need to bring the people the subject matter experts to the front of the line and give them an appropriate workspace to work in, if that means us being present with them while they complete their triage calls with those that are in the marginalized community. And Gord, I'm not sure if you have anything to add on that.
Yeah, I think that there's some unique aspects of being in Hamilton and Halton. We're kind of in a corridor where there's a lot of people who are quite transient, who go back and forth between Toronto and Niagara Falls. So sometimes crisis services work really hard to try and get people connected to services. We work really hard at that, but these people are no longer in our community in 2 weeks' time, 3 weeks' time. So it's quite challenging. And as we said, we do the best we can with the services we have, but sometimes we find certain people, their needs aren't being met through the services we currently have, and then we have to add more services. So much like Hamilton has their social navigator program, Halton has recently started up their complex case service coordinator, pretty much duplicating the same kind of thing, because we have these repeat people who the normal crisis services are not adequately meeting their needs, and they're kind of falling between the cracks. So we have this complex case service coordinator who's kind of able to pick up those people who kind of are repeat over and over again. So the homelessness piece, that's a really big issue, because there's not any places. If the person doesn't need a hospital and they'd be appropriate for a shelter, there's no shelter beds. We have only one male shelter facility in Halton, one female shelter facility, and then we have what's called the CMHA safe beds. Now that's a 5-bed facility, and people can stay up to 30 days. So in a month, 5 people get the use of that service, and there's obviously a lot of other people that could possibly use it. So we don't have a lot of opportunities that way, and we're trying to do more with less. And again, 3,500 people coming to the attention of 911 for mental health crises, and limited places to take them. If hospital is not appropriate, and usually isn't, then where else can we take them? How else can we stabilize them? 5 beds in a crisis bed facility that can be used up to 30 days a month, that isn't really putting a dent. And those have to be referred by police officers. So sometimes the 911 services shouldn't be involved, but there is no other way to get access to those crisis beds. So now we're foisting it back on 911 services and bringing them involved when they normally wouldn't or shouldn't. So those are some of the unique aspects of kind of Halton and Hamilton. We kind of share the same successes, but also the same challenges. Yeah.
All right, so we'll move on to my final question, and then when we're done with this, we'll go over to Erin to take questions from the audience. So I hope everybody's entering their questions. So we'll start with Gordon Pete. So back to you guys. Given this year's conference theme, what does inclusive justice mean for the future of crisis response across Ontario, and what do you hope to see?
I'll tackle this to start. Inclusive justice essentially means bringing in the community partners. In my vision, sometimes there's certain lenses when you look through a police lens, it's not the right lens to be looking through. And like I had said in the first question, sometimes we elevate a crisis to an emergency. And like Gord said, maybe because we need to trigger police to get a safe bed. So maybe we do need to look back at how can we redefine and reinvigorate the models that are presently out there to give the community exactly what they want. Sometimes they don't want a police officer with a gun on their hip showing up at their front porch. And to be quite frank, I don't blame them. And it's about listening, inclusively listening to the community, whether it's the marginalized community, whether it's the Black, BIPOC, Indigenous community. We have to do better as police in order to work with our community partners to show them that, hey, we want the respect. We want to be able to give back and help our community partners when they're dealing with the crises that usually fall on our laps, and bring it all together and work a little bit more cohesively.
And I would just add that we are doing the best we can with the models we have, but most of that is influenced greatly by the Mental Health Act legislation. And if we're going to implement more co-response models where maybe police aren't required, then the Mental Health Act is going to have to change, because, you know, Form 2s all have to be executed by police officers. And Section 17 of the Mental Health Act says the police powers of apprehension. We don't have a model like they do in England where a paramedic and a nurse can go out and assess somebody, and they would have the authority to apprehend somebody if required and not have to have police involved. I mean, we don't have that kind of legislation, so that's also an aspect. But even if we did have that, there are times when a person is suicidal and flees the area, and the phone has to be pinged so we can locate them. Only police, again, have those abilities to get involved with Bell Security and have a phone pinged. And so there's many different things that we may have to adjust in order to adjust the models to better meet the needs of the community and keep people safer. But that's, again, legislation-wise, that would be the first thing I'd have to take a look at.
Well said, Gord.
All right, Charlene and Lori, what would you like?
I'm not sure we can top that. That I ditto. But I think the only other thing to add that I'd like to see in terms of inclusiveness is that really treating addiction mental health as a healthcare issue and not something that needs to be criminalized over and over. And then how we can have the keen access or right access to services where everybody can have access, that are culturally safe services, that are appropriate services, kind of right intervention at the right time. I think that comes with a lot of the fact that a lot of us, don't have the staffing levels and we would like to have to support the needs and the complex needs of the community. And so, obviously, we are very valued with our police partners being involved because they do bring an element of safety. And like Gord was saying, there's some things that they can do that the mental health components can't. So we would need to see legislation change, but also leading from, a healthcare perspective, I think would be more inclusive for mental health and addiction concerns.
And I really don't have anything else to add. Lori,
I know they did really good, eh?
Yeah, we've spoken a lot about this, so we're totally on the same page. But yes, Gord and Sergeant Wiesner, very, very well said. I agree completely.
Right, Liberty, what would you like to see?
I just want to add, I think really looking at a person's basic needs and how do we have a client's basic needs met before we're really focusing on their part of their own recovery and their journey to wellness. Like, how do we support this? And also, how are we allowing a person to cope, heal, regulate, and meet their personal goals, and looking at their spiritual, mental, physical, and emotional well-being overall. And reducing some of the barriers for people and being able to provide them with a voice and what they need and help them be part of the journey, other than, once we have them in our Safe Bed program, really focusing on their goals and how do we get them to the next step, I think is really important as well.
About you, Raquel, what does inclusive justice mean for you? What would you like to see?
Hard to go last on a question like this because a lot's been said. So, I definitely agree, with everyone. The things that resonate with me would definitely be the low barrier pieces in terms of the system and how it's set up. We have clients that come in as refugees and they are still maybe in the process, or they're here illegally and they're afraid to access services or ask for services or go to a shelter because they feel like, somebody is going to call immigration. So I think there's a lot of work to be done in terms of, just the client feeling safe and being a part of their own mental health journey. Definitely wanting to just really emphasize the low barrier piece. Learning that, this kind of work can't be done from an equality space. It needs to be done from an equity space because not everybody is going to need the same thing and not everybody is starting from the same point. Right? There's a lot of assumptions built in to the system that we already have. When people say, if you need a psychiatrist, just go to your family doctor, get a referral, go see the psych. It's not that easy. It's not that simple. So being able to make things a little bit more palpable for the people that need mental health support to not have to jump through that many hoops, because it is very, very difficult for the clients that we are seeing that have, very high needs and almost every social determinant of health unmet. What I hope to see would be to see a lot more of these community crisis mobile teams pop up across Ontario, across Canada. My idea was to have one attached to every police division that we have, because I think it makes sense for us to build healthy relationships, with police, because we do need them. At the end of the day, we are mental health professionals, but they have their lane. We each have our lane. We're not taking work away from anybody. I think we can definitely work in tandem, and it's about, really helping to build that trust within the community. So yeah, I hope to see a lot more of this across Canada soon.
so much, everyone. So I think now we're going to pass it over to Erin to navigate us through some of the audience questions.
There are some really fantastic ones from the audience. So thank you everybody who submitted questions. I'm going to start sharing some of them on screen, and then everyone can begin to vote on the questions that you would like to have answered first. Okay, so hopefully those are on screen currently for people to vote on. One that I can begin with, because it already has many people requesting confirmation, and I believe that this person is referencing the Toronto Community Crisis Service, because the question is, they're asking for confirmation if this service has expanded outside the city of Toronto, so for example to Mississauga, Brampton, Oakville, etc.
Okay, so we haven't expanded to Mississauga, Brampton just yet. Still just covering just the GTA. So for right now, Taibu is covering the Northeast, which is the Scarborough area. Downtown is covered. Northwest in terms of Toronto, Rexdale, really Midtown. We haven't branched out to Peel just yet.
Okay. The next question is specific to police and coast. And the question is, apologies, I'm looking at the questions on another screen. I'm not ignoring everyone. So specifically around police and coast teams attending wellness checks, mental health calls, Form 2 related calls, where the individual unfortunately does end up being, does face criminal charges as a result of perhaps their mental health issues. What sort of threshold or discretion exists in situations like this for those attending officers who are having to sort of weigh whether or not to arrest the individual, or whether they should be, like, the distinction between being taken into custody versus being apprehended under the Mental Health Act? So that is the next question that has been asked, is for clarity on that, on those kind of distinctions.
From a police standpoint, I could answer from a Hamilton lens. We do wellness checks, and we're talking about if there's criminality related to a mental health call. This is one thing that we're always telling our community partners, that when you insert police, we have to use the lens of the Criminal Code of Canada. That unfortunately has to take precedence for us. Could we use discretion depending on the case? A lot of people don't understand that when there's domestic violence involved, we have to lay a charge. Even if, you know, one of the calls came up, it was a elderly male with onset dementia, but at the end of the day, we don't have a choice other than to lay the charge and allow the course to take its time. It's a terrible situation, but is there ways to improve that? Yeah, and we're trying to adapt ways with our crowns and with the court system to look at a larger view of how things look. But when it comes to the criminal code and police are inserted into a mental health act, that's our lane of traffic that we have to operate in. And we don't expect people to understand it, but the reality is that there's a victim. We have to obviously put carriage into that investigation as well as the mental health piece. So it does at times lean back and forth, but the very, very last thing we want to do is put anybody in jail. We obviously want to divert.
Yeah, and I can just add to that as well. We are in the exact same situation. If there's a criminal offense, there's a victim, we are going to be, laying that charge if there's grounds, and if, we've met the ladder, which is, like diversion, different things like that. But the other piece of it is, in laying that charge and putting them before the courts, it also allows for a lot more referrals and things of that nature that can be determined through the court, and they could go into like the therapeutic court as well. So there's different ways, at least here in London, to manage individuals that are clearly suffering from mental health issues that have been charged.
And if it just to add to Inspector Humble's piece, we're actually working with the Hamilton Wentworth Detention Center. We're creating an MOU which allows us easy access through the back door to help those people that were arrested with mental health pieces, to allow them to get the proper supports they need when they come out. So they're just not being re-released into the community, into that vicious circle.
I also think it's a hard question to answer because it's such a broad brush. Is it a criminal misdemeanor? Is this an assault? Is this a sex assault? Is this a domestic violence situation? Is this, again, a nuisance kind of mischief charge? So there's many different things. The MCERT teams, when they respond, they look at what's the best course of action given right now. Doesn't mean there's not going to be a charge laid later, but if the mental health is the key piece that we need to address and the person is apprehendable, then we will give the hospital a letter saying, please notify us upon this person's release, because we do have other things of a criminal matter that we have to address with this individual. But if first and foremost, their mental health is the biggest aspect of, they are in a very distraught state and their mental health is the biggest piece of the puzzle, then we will address that. It's not going to be, it's not an either or question, it's a both and, but right now, what is the biggest piece of the puzzle? What's the best interest of everybody, the community and the individual in addressing this particular situation right now? What do we need to do to get the things moving in the right direction? What's the safest and best way to move forward? So it's not an easy question to answer because there's so many variables about what we might be talking about here.
Yeah, and I can agree with that. So I was thinking in my mind, but didn't say it out loud, that so if we're in a scenario where a serious crime has been committed, but this person is clearly in crisis, is apprehendable, they would be apprehended and then the charges would be laid. But like you said, initially, we're definitely dealing with any sort of medical and mental health issue that's going on before that piece. At least, like you said, broad strokes, but that's generally how it is in here.
Thank you. I believe we're ready to move on to our next question. I am guessing that the individual who submitted this question is from Southwestern Ontario, because they have asked for that particular region. How do you connect or support Indigenous communities when they are in crisis? And a sort of link to that question also is whether or not there are established partnerships with Indigenous police and healthcare supports. The sort of third part of their question is how do you respond differently to crises if they occur on reserves?
I can share a partnership real quick that we have with the Hamilton Police. When we initiated our risk pilot, we have a very large Indigenous population in Hamilton, and we knew that we needed to have that partnership with the Hamilton Regional Indian Center. And it was from years of actually getting off your butt and going into their office and having meaningful dialogue, where 3 years later, that partnership is desired. And that's what we were able to do with the Hamilton Regional Indian Center. We're now, with that grant money, we're actually paying the salary of an Indigenous navigator to be deployed with police into the community when dealing with homelessness, addiction, and mental health. Is it the best we could do? We could always do better. I would love to bring in every section of the Indigenous partnerships within the community, but knowing that they need to be represented was our priority in getting them a part of the team.
I can answer from our perspective, also being surrounded by many Indigenous communities, that I agree with Pete, is that we need to do better. In terms of our crisis center, so not our mobile teams, we have had some good relationships and conversations and connection building with the Chippewa First Nations of the Thames Community Health Center, so that when we just did a major renovation of our crisis center, how do we make sure that it was representative of the BIPOC community? How do we make sure that it felt like it was culturally safe? And then could they provide us any kind of tips, techniques? And so for one thing that we did within our community is we had an art project from an individual that was actually a staff member of ours studying to be an art therapist, which was super cool. And she approached the youth BIPOC community, and they have created murals that are in our weight room. Something small that they have done, but we definitely need to do better by reaching out with the police services. In terms of our MCERT teams that are more rural ones, I know that we do have connection with also Oneida as well, and they sit on our situation tables. And so that's where some of our connection happen, is more at the situation tables in terms of being invited out to situations that might meet the threshold of acutely elevated risk, and to see how we can get community engagement and individuals involved and connected to right services.
Thank you. Our next question is specific to brain injury. And so the question is, what training is provided to the various partners on on crisis response teams, in relation to brain injury, given its prevalence and given that there are not, as far as we know currently, crisis services specific to brain injury. This individual is asking for that clarification. What are the training requirements related to brain injury?
I can maybe jump in from our perspective again. So in terms of acquired brain injury training, it isn't just specific to our mobile teams, knowing that across addiction and mental health, especially with addiction-related concerns, we see an increase presenting concern of individuals that may have had an acquired brain injury. So a lot of our staff will get what we call an onboarding training for that, but we also leverage our community partners that specialize in acquired brain injuries to help, keep our education up to date. But in terms of specialized service, what we try and do is just with people's presenting needs, just meet them in terms of, we ask the active questions. Have you ever, lost consciousness as a result of a bang or blow to your head? Have you ever been diagnosed with an acquired brain injury? Because it allows us to at least have that information so that we can make sure that we're developing appropriate and right connection to services, treatment plans, and understanding of presenting behaviors and concerns as well.
And over in Hamilton and Halton, we do CIT training, 40 hours of training, but we don't specialize in ABI, but we do a section on ABI. We do a section on dementia. We do a section on people who are neurodivergent on the spectrum, that kind of stuff. And a vast majority of our staff are nurses who have all had to do training in neurology. I mean, when I first graduated, I worked for the Acquired Brain Injury Services of Hamilton prior to getting hired by Coast and later MCERT. So our nurses are well-versed, but in our onboarding of our social workers, our occupational therapists, we do cover that to some extent, but it's no more than we would spend on dementia. It's no more than we would spend on people on the autism spectrum. It's no more than we would spend on FAS. It's just one of about 12 different compartments that we would cover, but it would not be a huge compartment. It would just be on equal kind of level. So, but the strategies to intervene are just slightly different than if you were dealing with somebody with. So it depends, again, what the ABI, where it is and what the symptomatology is, whether they present much like somebody with dementia or somebody much like with schizophrenia. Again, there's similar strategies based upon more of the behaviors more than the actual diagnosis. So that's kind of how I would approach that question. Yeah.
Similar to what was said over at Taibu, we also, before we even launched, we had to do 6 weeks of intense training that encompassed, again, a bunch of different things. So we also did a couple of days on autism, ABI, and it's consistent. So we did that, a year and a half ago when we started, but we're also doing ongoing training all the time. So as we come and kind of notice certain trends, so neurodivergent clients has been a trend for us lately. So we did go out and, again, leverage some of our partners to kind of see, what do you guys have to offer for our staff to be able to assist those clients. And it is Taibu wide, not just TCCS, because we are a community health center. So sometimes we are getting some of those clients just through primary care services. So we have been putting some focus on, dealing with clients with ABI, autism, and those different things. But it's ongoing for us in terms of the training.
Thank you. We still have a number of questions. So one of these questions I think we haven't had an opportunity to address fully so far is that a lot of crisis response services be concentrated obviously in urban areas, larger cities, for example, in larger municipalities. And so this, the next question is in relation to...
Sorry, Erin, your sound is cutting out again.
Yikes.
That's better. Yeah.
That's good. Sorry about that. The next question is in relation to smaller municipalities and rural areas. So, a lot of crisis response services tend to be concentrated in bigger cities and larger municipalities. And so the question from this individual is, how do those service models trickle down to smaller cities and rural areas?
I can speak to for us here. So again, Taibu, we're covering most of Scarborough, but the Indigenous pilot that's been being run by Two Spirit Nations, which is an agency downtown, they actually have gotten funding to cover all of the GTA. So they are going into the different rural areas and servicing the Indigenous population. And their pilot is very unique in the sense where all of their staff is Indigenous. So they're making sure to do things from a very culturally sensitive and appropriate approach for that reason, and have made provisions to be able to give services, you know, in those rural areas.
And from our perspective, so we have, in terms of Middlesex, Oxford, and Elgin counties, we have, you know, some very like rural kind of farmland, some smaller villages, some towns, and some cities, smaller. In terms of our MCERT teams, that's why I said we kind of have each of the different models, because the way that it works in our smaller communities, we really are wanting the services to be the same across the board, except having that local feel. So what might work better for that community? And so I can give you an example, like in Woodstock, they have a model where they're embedded within the police detachments, and they also service the city and OPP. So it's like kind of working together. So the city of Woodstock working with the OPP. So they'll do both, because it is kind of blurred boundaries on where does like the smaller city or larger city of Woodstock, depending on your perspective, I guess, and you know, the OPP jurisdiction. But in terms of connection, it is really about building those relationships again around what is appropriate, what is going to make sense in that community. And so I think that what we do is that all of our data and all of our statistics and everything are the same across the region. So we try and do that regardless if it's a rural area. Obviously, some of the differences are we can respond to more live calls in, say, London, because travel time. So those are things we have to take into consideration, is travel time and getting back and getting to detachments. But in terms of the quality of the service and the relationship with the partnerships, they're the same across whether we're a large urban center or we're working with the rural, the smaller community.
In Thunder Bay, our impact team directly works with just Thunder Bay Police, and our regional line through our phone and text line covers, like I was saying, from Wawa to the Manitoba border, just in that area. So calls to 911 through OPP can, in certain areas, there are some teams that will go out with OPP in order to service.
Thank you so much. This next question is sort of generally around your experiences, and perhaps this is best placed for those who are part of the process of seeking funding for your crisis response service. The question is generally, from this individual's perspective, to them it appears that it is more difficult sometimes for mental health agencies or other community services to access funding, and they're asking why that may be the case.
I would say that the number one factor about whether you're getting this kind of funding for these kind of services is which LIN you're in and how much they value crisis teams, mobile rapid response teams. LIN 4, in my opinion, in the whole province of Ontario, LIN 4 is the one that values those teams the most and has been very much willing to take the risk of funding those programs, continuing to fund those programs, invest more in those. LIN 4, by far, I think, has spent the most dollars in getting crisis and mobile rapid response teams up and running. I can't speak to what everybody else is doing, but LIN 4 has been, you know, Niagara, Brantford, Hamilton, Halton, well, parts of Halton, yeah, that and Halton and Norfolk have been very much well funded by the LIN, but that's LIN 4. If you go over to LIN 6, which is kind of Peel and that way, we in our area, which is also bridged by LIN 6, have not received any sort of funding for similar programs, even though we are 2/3 of Halton is in LIN 6, but we get all of our funding for our mobile response team from LIN 4. So yeah.
So sorry. So Aaron had asked if we could get some clarification on what a LIN is. So I just thought I'd jump in. So LIN is a local health integration network, and they've actually been disbanded. It's now Ontario Health. So there were 14 LINs across Ontario. Some people remember them by their number, or some people remember them by their region. So LIN 4, I think, is the term you were using, Gord, was Hamilton, Niagara, Haldimand, Brant, LIN. But now there's 5 Ontario Health regions. So Ontario Health is the agency funded by the Ministry of Health that does the regional planning and funding. So it is, the funding does come through the LIN. Ontario Health does advocate to the Ministry of Health for areas of need. And when we have had funding in the past for different mobile crisis response teams, we have worked with our partners in Ontario Health to identify the areas of need. And we're looking at, repeat ED visits, but then we're also working with our partners in the Ministry of Solicitor General to understand from the policing side where the concerns are. And that's historically how we have decided at the ministry level how to allocate the funding. But I would just suggest moving forward, find yourself at your local HSJCC network tables, your community safety well-being tables, get to know all your partners, really understand who's in your community, who's doing what, because the more successful programs are the ones that are integrated with all of the other services in the community. I think we've just heard a lot about different partnerships in the communities that these guys are leveraging to have successful programs and to best support their clients. So those would be some of the suggestions that I would have, putting together proposals that include a lot of partners and integration within your community to make sure that there are the wraparound services for people, and then reaching out to your Ontario Health Region mental health lead. Conversation.
And I think that's all great advice. I think from my perspective, too, one of the things that is really key from an individual organization is to be able to, exactly what Dianna says, is but leverage how is this going to be a collaboration within the community. So having data and statistics to prove that. And then I think it is about our data and our data quality. So what we're capturing. So always taking a look at, what you're capturing. Is it highlighting what the funding is requesting of you to highlight, and to really tweak that as you need. So we talked about a lot about PDSA cycles. So we're constantly in a quality state of flux where it's okay, what do we need to be capturing now? What do we need to be doing differently? And we know everybody doesn't love paperwork, but if we can really focus on, those statistics and being able to prove that, I think that helps sell cases because it gives you the facts.
Thank you for your responses. I think that's some very specific, concrete advice for anyone who's looking at this type of funding application. Our next questions are in relation to. We'll start maybe with one of the clarifying questions. So there's someone who is asking specifically around what apprehension under the Mental Health Act looks like. What does that entail? And when there's been references to being formed under the Mental Health Act, what does that look like and what does that entail?
Don't everybody speak at once, I guess. I'll go.
Reminding everyone that I don't believe there are any specific legal experts on the call, so we were describing this for the purposes of understanding.
And I'm sure Gord can help me articulate this as well as Inspector Humble. The Mental Health Act is very vague. Section 17 gives us a broad authority to apprehend. That's just bringing a person to the hospital. The forming happens at the hospital when the doctor says, hey, we need to keep this person in custody to ensure they get the proper medical help they need. When it comes to the grounds to apprehend, it's no different. I like to say when me and a police officer decide we're looking at an arrest, I feel I have grounds to arrest. This officer might not feel that there's grounds. So it's all dependent on the observations of the person who's in crisis. But essentially, if you want to put it in a nutshell, if a police officer is going to apprehend, the person is either have suicidal ideations, homicidal ideations, or shows an inability to care for themselves. Those are the 3 big factors. Gord, I'm not sure if you could clean that up from a medical side. You're much more.
Yeah, so when people want to get help, that's great. People can obviously get help voluntarily, but when people need help and they don't necessarily want help, there's really 3 provisions in the Mental Health Act for that. Section 15 is the ability of a family doctor, a medical doctor, if you will, to put person on a Form 1. That's Section 15 of the Mental Health Act. Section 16 is when usually it should be 2 credible sources going in front of a justice of the peace, and they swear out information pertaining to whether the person's a danger to themselves, a danger to others, or showing a complete inability to care for themselves. That's Section 16. And again, the police powers of apprehension is Section 17 of the Mental Health Act. Obviously, we want people to get help, but sometimes they're unable to truly understand the nature of what's going on, and that their decision making is so impaired and that they require help but don't want the help. So those are the 3 provisions in the Mental Health Act in Ontario as it stands right now.
Yes, and with that, like they both had just said, we would then apprehend based on one of those 3 or all of those 3 components, and then we have to forthwith, like, immediately take them to a hospital where they are assessed by a doctor who then determines whether they will. If the form hadn't already been issued, if it's just the police showing up, the doctor at the hospital needs to commit them to a Form 1 or issue a Form 1. And otherwise, in the other cases that they were talking about, like if the family doctor issues one, or it's the form that's issued by the Justice of the Peace, then that's submitted to the police, and then we again have to go and apprehend, which I know we are moving some of ours over to the coast yes now.
Oops, I just realized I'm on mute. Sorry. I just said thank you, everyone, for clarifying those specific terms that have been used. We're running low on time, so this may be our last question. Someone is asking about the legislative change that was mentioned earlier during the discussion. And specifically, they're asking about how people with lived experience can get involved in helping to push for that legislative change. So I'm not sure if anyone would like to begin sort of commenting on that piece.
It's been a long time since we've had our last legislative change. It would have been December of 2000 when Brian's Law was the big addition, was basically community treatment orders. That's the last time we've had a major revision in the Mental Health Act. When I first started doing crisis work back in 1997, it was Section 11 of the Mental Health Act that allowed police the ability to apprehend somebody. It's now Section 17, but we haven't had a revision since December of 2000. So in terms of how somebody gets involved, to be involved and give that input as to what changes need to be made, that I'm going to leave to somebody else.
Maybe we do have time for one last one. Oh, sorry.
I was just going to advocate on the legitimacy of the lived person experience. We actually rely on them quite a bit within our model on risk. We understand the value that it brings, and we actually lean on lived experience in the community to assist with those highly acute clients that we deal with in the community, because we know that lived experience person has the experience. I don't, and that's what makes them the subject matter experts.
Just to, I guess, echo what Pete was saying, we also, on our team, it's built into the model that we are hiring people that have lived experience and or clinical and community experience. So for us, it's very, very valuable, because it's not all about, the clinical approach and the risk assessment. Sometimes it does take somebody who has, been in that position before to understand what community actually needs. And I think in terms of the legislative piece, us being involved with the City of Toronto, we're trying to do as much advocacy as we can. Our case managers do a lot of advocacy, and especially some of the ones that have lived experience, to just kind of bring some of those barriers to the forefront, so they can understand the importance of making changes within the system and the legislative stuff. So it's we don't discount the value of people with lived experience in this whole process, because it's invaluable for us.
I'd just like to add that within our programs, we use the Ontario Perception of Care. So we get some feedback for people with lived experience, and we utilize that information in order to look at our own procedures and to best meet the needs of clients. I can't speak to the legislative, But we do definitely, even in the CIT, the crisis intervention training, there's a piece on having somebody come and talk with lived experience. So it gives a better idea of what people are experiencing in the community. But I would say for sure our OPOCs, and that eventually goes back to the clients, and we talk to the clients and utilize some of that information in order to make our procedures better for the people that we are supporting.
Thank you so much. Raquel, this last question is specifically for you, so not to put you on the hot seat. So the question is how other communities can go about engaging with their municipalities if they believe that a community crisis response model is appropriate for their community, and how they go about developing a service like that.
Yeah, so I think, where Taibu is concerned, we were approached by the city in terms of a part of the SafeTO 10-year plan to see if we wanted to be a part of this. Prior to that, there was a lot of advocacy that happened from the, we went to the MPP's office. We went to so many different, government offices, leaders in the community to help us push just to even get Taibu to begin with, right? Taibu took about 3 years before we were able to actually become a community health center, because we had to prove and push that there was a need for specialized services for the Black community, for the Indigenous community. So for anybody that wants this sort of service, it really is about a lot of community rallying and going to, the people that have the power to make those decisions, making it a very big deal. Like I said, we had to do a lot of advocacy, at City Hall to prove that this was something that we needed. So I would encourage anybody that really wants this sort of service to, also to come and talk to us in terms of just, the nitty-gritty and the details as to how we went through everything. But community organization, focus groups, having those conversations to figure out how to push those things through to MPPs is crucial. Very, very important.
Thank you, Raquel. And we are right around the time where we have to unfortunately conclude our Q&A session with the audience. So if we didn't get to your question, I'm so sorry about that. But at this stage, I'm now going to turn it back over to. Were you able to hear me? Oh, jeez.
We can hear you now. I think you're just stepping away from your computer. It's not.
I think I'm an AT&T commercial today. I'm so sorry, everyone. That concludes our session with the audience Q&A. I'm so sorry if we weren't able to get to your question, but I'm going to turn it back over to Dianna at this point.
So I just want to say, wow, like so inspiring to hear, the creativity out there to make sure that the services are in place for people in Ontario and making sure they get what they need, but also keeping our communities safe, right? It's two pieces. I think ultimately we hope that everyone has the services they need before they reach a crisis situation. I'm hoping that eventually we're all looking for different jobs because we don't need to do this anymore. But I know we're not even close to that. I can fully admit that. I wish I had a magic wand to create housing for everyone. It's a struggle that, we see every day. But thank you to all of you. You talk about some of the repeat people that you're seeing versus unique individuals, and by repeating that, you're helping keeping them out of jail. You're helping to keep them out of jail. You're helping prevent them from getting arrested and ending up in jail, or preventing them from ending up in a forensic mental health system, because we know those are the two systems where they can't say no. So that's where people end up when they fall through the cracks. And I'm sure it's frustrating for all of you to see the same people again and again and not have the services to refer them to in the wait list. But thank you so much for all the work that you're doing. And for everybody else in the audience, if you're not involved in a mobile crisis response team, I really encourage you to look up the framework and toolkit. There's so much information in there, and also some tips and tricks on how to get something started, right? So a lot of tools in there. So thank you again to everyone on the panel. Thank you, Erin and the HSJCC, for putting this conference together. It's been a pleasure for me to be part of this. And hopefully we'll see everybody soon.
I'll echo Diana's thanks to our panelists, and thanks also to you, Dianna, for your fantastic moderating skills. Just a couple of housekeeping notes before we jump off. This is the end of our keynote panel, and we have now reached our afternoon health break. So I would encourage you to visit some of our poster presentations. There's some phenomenal resources and information there, and the poster presenters are there to also chat with you live to answer any questions you may have about the resources they're presenting. We also have a phenomenal session on mindfulness with Mike Dunn that you can access during this health break. And of course, as always, a reminder to please fill out the evaluation surveys that are on this panel page.